The finding of a cystic hygroma on prenatal ultrasound is an important clue to rule out chromosomal anomaly. This case was done with 25-year-old Gregory 5 at 29 weeks gestation, whose last childbirth was 2.5 years prior to presentation. On routine prenatal ultrasound, a multilocular cystic lesion was detected, which is consistent with a cystic hygroma. Now, there are key considerations when cystic hygroma is detected on ultrasound. It's important to assess associated structural anomaly, especially cardiac and skeletal. It's equally important to rule out non-immune hydrops because hydrops are associated with cystic hygroma has a mortality of about 90%. There are common genetic associations with cystic hygroma, from Turner's down to Patau's and Peters. But the most common chromosomal anomaly associated with cystic hygroma is Turner syndrome, where facilities exists, unlike where I practice. Where I practice, there are no facilities for karyotype, not to talk of chromosomal microarray. The expertise for fetal echo is also limited. So it's difficult to say that the cystic hygroma is isolated. But when it is isolated and chromosomal anomaly is ruled out, in some cases, when it's small, especially less than 2 centimeters, can resolve spontaneously. But here you can see this is not small, this is large cystic hygroma. Any cystic hygroma measuring more than 5 centimeters is considered large. Here, this maximum dimension is up to 10. So this is large. That's number one. Number two, you can see the multiple septations. The literature says that cystic hygroma is classically linked to Turner syndrome, especially when large and septated. Here, it's large, multi-septate. So, when we consider Turner syndrome in this case. And one clue that will help us as to whether we are dealing with a Turner syndrome or other chromosomal anomaly is to check the gender. Here you can see hamburger, and this is the hamburger sign. So, this is a female fetus with large and multi-septate cystic hygroma. So, my working diagnosis here is that this cystic hygroma is likely to be associated with a chromosomal anomaly, most likely Turner's syndrome. Now let's play this video. It's intercranial, operated normally in intracranial structures. The multiseptate cystic hygroma, a bit lipo, normally septate placenta. Again, transthalamic view, nose chin view, fetal orbits. The multiseptate cystic hygroma, with the multiple septations. Apparently normal spine. Trying to get the transverse view of the fetal heart to rule out any structural cardiac anomaly. Another view of the multicepted cystic hygroma. So, for example, view, descending aorta, left atrium, right atrium, right ventricle, left ventricle, moderate band, intact interventricular septum, normal offshoot, no pericardial effusion. For example, normal for chamber view. So, look at the three vessel view and the three vessel trachea view. Apparently, no one. So, no obvious structural congenital heart disease. Remember, when there is large multicepted cystic hygroma, is often associated with Turner syndrome. So it's important to demonstrate its gender. Here you can see it's female. So this supports the fact that this could be a case of Turner's syndrome. The learning points here are one, to exclude chromosomal abnormality, especially Turner syndrome. More so when the cystic hygroma is large and multicepted. Number two, it's important to rule out other congenital anomalies, but the focus is more on cardiac and skeletal malformations. So a fetal echo may be necessary. Discussion with the pediatric surgeon is key, but let's not forget that airway management is important post-delivery. So anesthetic review is equally important in the management of these cases. Thank you very much for listening.